A 7-year-old child present with a 3-day history of severe sore throat, fever, dysphagia, and headache. On examination, there were tonsillar exudates and palatal PTP and tender anterior cervical lymph nodes. কি মনে হচ্ছে কি হতে পারে? What will be your provisional diagnosis? Pharyngitis and anything else? সেটা কি হবে? এটা হিস্ট্রিটা কত দিনের? তাহলে কি হবে ওটা? Acute tonsillitis. How will you proceed for diagnosis? এখনো যদি তোমরা পার্টিসিপেট না করো তাহলে কি করে হবে? শুধু মোবাইলে স্ক্রল করলেই হবে? সব আসছে মোবাইলে ফটো তুলছে, স্ক্রল করে যাচ্ছে, কেউ কেউ কানে হেডফোন গুঁজে বসে থাকছে, কোনো ইন্টারাকশন নেই, কিছু নেই। তারপর পরীক্ষার সময় জিজ্ঞেস করলে তখন পাথরের মতো বসে থাকবে। So it could present as pharyngitis or tonsillitis anyway. So what about the causative agent? Most commonly you have to remember about the bacterial causative agents like Streptococcal pyogens. A very important disease is Corynebacterium diphtheria. Other than that, the major would include Arcanobacterium humoliting, that is a very frequent cause of pharyngitis, especially in especially in adolescents. Other than that, the very important causes would include the viral causes. Important viral causes include influenza, parainfluenza viruses, Epstein-Barr virus, enterovirus, Coxsackie virus, and adenovirus. So whenever you are asked about the causative agents of pharyngitis, you have to write like this: the bacterial agents and the viral agents. Now how will we approach? We can go for the specimen of choice will be the throat swab. We can go for a direct antigen detection test on the throat swab itself for rapid diagnosis of streptococcal pharyngitis. Otherwise, we can also go for culture. The culture is a definitive mode of diagnosis. Now, why we should try to determine the causative agent? Because streptococcal pharyngitis may have some complications. What are the complications? Are কি বলো ওটাকে? পুরোটা বলো, সব শর্ট ফর্ম চালালে হবে? Post streptococcal glomerulonephritis and acute rheumatic fever. These are the two dreaded complications of streptococcal pharyngitis. Hence, identification is very important. Okay, now let us look at another case. A 6-year-old child came with high-grade fever, pain in the throat. On examination, the child had a toxic look. Oral examination shows a white patch on the tonsillar bed. What will be your provisional? What will be your provisional diagnosis? কি মনে হচ্ছে কি হতে পারে এটা? ফিভার, সোর থ্রোট নিয়ে এসছে, বাচ্চারা টক্সিক আছে, হোয়াইট প্যাচ পাওয়া যাচ্ছে টনসিলার বেডে, কি হতে পারে? সেকেন্ড লাইনটা কি বলে? অন এক্সামিনে চাইল্ড হ্যাড এ, তার আগে কি লেখা রয়েছে? টক্সিক লুক মানে কি? দ্য চাইল্ড অ্যাপিয়ার্স টু বি ফার মোর ইল, দেখে মনে হচ্ছে খুবই খারাপ আছে, ঠিক আছে? যখনই বলা হচ্ছে টক্সিক লুক মানে কি? কি কেস এটা? This is a case of what type of diphtheria? সেটা বলতে হবে তো। How many types of diphtheria? It's a case of fascial diphtheria. Fascial মানে কি? Oropharyngeal diphtheria. What are the other types of diphtheria? আর কোথায় হয়? What is the causative agent? Corynebacterium diphtheria. What is the most important part of the pathogenesis? It is the production of diphtheria toxin. The toxin has got two parts, fragment A and fragment B. The fragment A is the important part of the toxin which inhibits protein synthesis. Now, how can we approach for diagnosis? The most important for diagnosis is, after if you suspect that this is a clinical case of diphtheria, take a specimen. What will be the specimen? Throat swab. Send it to the laboratory with laboratory intimation. You have to inform the laboratory that you are suspecting diphtheria. Okay. Furthermore, you have to initiate infection control protocols. What will be the infection control protocol over here? What is the mode of transmission of diphtheria? What is the mode of transmission of diphtheria? It's a droplet borne. How can we prevent droplet borne transmission? Laboratory diagnosis, when we will be taking the sample, we have to take the white patch. This is called as pseudomembrane. Why is it called pseudomembrane? Why is it called pseudomembrane? What kind of test you will send? First, you have to send one swab for gram stain. The gram stain will give us the morphology. Next, we have to send another swab for Albert stain. That would give a probabilistic diagnosis. And also you have to send it for culture. Now, what we will be getting? On gram stain, we can find club-shaped gram-positive bacilli. And on Albert stain, we can find green color bacilli with blue colored granules. So, if these two findings are there, then we can confirm that this is a case of diphtheria and start management. Culture can be done on blood agar, chocolate agar, or specific agar for diphtheria like telluride agar. Identification can be done with biochemical or multitoph. A very important part is detection of toxin. How can we detect toxin? There are in vivo test and in vitro test. In vivo means when we apply it within living beings, that is the animals. That would be the animal experimentation on guinea pig. In the in vitro test, we can go for LX gel precipitation test, or we can go for ELISA or nucleic acid amplification test for detection of the genes responsible for the toxin, or we can also go for cytotoxicity test on cell lines. So, this will be the part of your diagnosis. Okay. So, if you suspect a case of diphtheria, what you have got to do? You have got to take at least 3 samples. One for gram stain, one for Albert stain, one for culture. And you have to mention to the laboratory that you are suspecting a case of diphtheria. Okay. Now, what will be the management? Most important is, after you confirm that this is a case of diphtheria, you have to give anti-diphtheritic serum or antitoxin. Because it's a toxinia, the definitive management is anti-diphtheritic serum, and that will, the dose of the anti-diphtheritic serum will depend on the stage of the illness. Furthermore, you have to add antibiotics. What is the role of antibiotics? It not only kills the bacteria but also reduces the production of toxin. Next, you have to give the patient vaccine also. After treatment, you have to give vaccination so that the patient must have antibodies against diphtheria. What will be the vaccination? That will be depend on the age of the patient. If the patient is an adult, we may have to give কি ভ্যাকসিন দেওয়া হয় ডিপথেরিয়ার জন্য? হ্যাঁ, বাচ্চাদের ডোজ কত, অ্যাডাল্টদের ডোজ কত? 17, 7, বাচ্চাদের 7। Okay, what you must remember, once we start antimicrobial therapy in a patient of diphtheria, after 48 hours, the patient becomes non-contagious. That means the patient becomes non-infective. So, from diagnosis till 48 hours of completion of the antibiotic therapy, you have to provide infection control measures so that the patient does not spread infection to anybody else. Okay. Furthermore, you can give chemoprophylaxis to all the people who have come in contact with the patient. Now, suppose you have started the patient on antibiotic therapy, you have given antibiotic therapy for about 1 week to 10 days, then what you will do? You must send follow-up cultures which must come negative before you declare or discharge the patient. Have you understood? So after treatment, at least 2 consecutive negative cultures should be there, showing no growth of diphtheria bacilli. Okay. এই যে লাস্ট এটা লিখেছে এটা বলতে পারবো কি? বুস্টার ডোজ উইথ DT/DT। ভ্যাকসিনসগুলো পড়তে হবে, ঠিক আছে? সব কিছু পড়িয়ে দেওয়া হয়ে যাচ্ছে, তোমরা তো কিছুই পড়ছো না। ওকে, নেক্সট কোয়েশ্চেন। 5-year-old child attended the OPD with history of fever, sore throat for 2 days. On examination, the child was febrile with small pustules observed on both the tonsils. Pustule মানে কি? This will be acute tonsillitis. ঠিক আছে? Acute tonsillitis আর কি হবে? Along with there will be pain in the tonsillar bed. The patient will complain of pain during deglutition, and you can even find the jugular lymph node, they may be inflamed. Okay, now look at the common causes. First 3 are all causes of pharyngitis: Streptococcal, Corynebacterium, Diphtheria, Arcanobacterium, Hemolyticum. All 3 are causes of pharyngitis. Etiology the same, ঠিক আছে? কিন্তু এখানে কোনটা আসবে? Vincent's angina caused by fused spirobacterial infection, ulcer or membranous tonsillitis. This will come into your differential diagnosis. And as far as tonsillitis is concerned, Epstein-Barr virus, which notably causes infectious mononucleosis. Try to recall infectious mononucleosis and adenovirus and enterovirus. These are the common causative agents of acute tonsillitis. Now, coming to laboratory diagnosis, like pharyngitis, you must take a tonsillar swab, okay, and send it for bacterial culture. One important question that may come in your practical examinations, that is the procedure of collecting a throat swab. So basically throat swab, and you may have to use, now কি টেস্ট করতে হতে পারবে? Again, Ramstein, Albertstein, and if you are thinking of diphtheria, you can send for Albertstein. Rapid antigen test. As far as the bacterial culture is concerned, send a swab for bacterial culture on blood agar. You can find streptococcal growth, confirm it. From serologically, we can diagnose with the rise of ASO titer or anti-streptolysin O titer. If the titer is more than 200, we can confirm that this is a streptococcal infection. But please keep in mind, this is a retrospective diagnosis. That means this titer will increase after the infection. Okay, it may not rise during the infection. So it's a more of a retrospective diagnosis. Okay. Now, what will you prescribe the patient? Most commonly, we give penicillin group of antibiotic. We can most commonly prefer other oral penicillins like amoxicillin. Okay. Now, next question. A 4-year-old girl came to the emergency room. Please keep in mind these words. These are some of the indications that you have to be very, very careful. Look in this question. It's a 4-year-old girl who came in the ER. ER means emergency room, not in outpatient. Okay. Next, with acute onset fever, productive cough and dyspnea for 2 days. What is dyspnea? Difficult to breathe. That means the child has fever, difficult to breathe, and productive cough. That means cough along with expectoration. The breath sounds were diminished on the left side with a dull note on percussion. কি মনে হচ্ছে এটা পড়ে? কি মনে হচ্ছে এটা কি হতে পারে? Fever, cough with expectoration and difficulty in breathing. And on examination we have reduced breath sounds on the left side. তাহলে কি মনে হচ্ছে? হ্যাঁ, যেটা বলো, কিন্তু ওপেন অ্যান্ড শার্ট কেস নিউমোনিয়া, এটা বলো, হোয়াট ইজ দ্য প্রভিশন? নাও হোয়াট আর দ্য ইটিওলজিক্যাল এজেন্টস? ইটিওলজিক্যাল এজেন্টস, হ্যাঁ, আবার ওই চাঁদা শুরু হয়েছে। কি বললাম? ব্যাকটেরিয়াল, ভাইরাল, এইভাবে বলতে হবে। আর এই একটা বলে থেমে গেলেই হলো? How will you proceed for laboratory diagnosis? আর আর কি করতে পারো? পেশেন্ট যখন তোমার কাছে আসবে, তোমাকে তো একবারে লিখতে হবে। তুমি তো বলবে না যে যাও স্পুটামটা পরীক্ষা করে এসো, তারপর দেখছি। এভাবে তো বললে হবে না। ব্লাড নেবে, আর ব্লাডে কি করবে? কি দেবে? সোডিয়াম, পটাশিয়াম? তাহলে ব্লাড নেব, এত আরবিট্রারি কথাবার্তা বলো কেন? So your diagnosis would be a lower respiratory tract infection, or you can even call it as pneumonia. Now, the common agents which cause pneumonia in the community would include strep pneumoniae, Haemophilus influenzae, Staphylococcus aureus. Okay, and in the hospital setting, most commonly we have Klebsiella, that is the gram-negative infection, Klebsiella, Enterobacter, etc. Other than that, whenever this question is asked to you, you have to answer by etiology. ঠিক আছে? Bacterial causes, viral causes, fungal causes, parasitic বলতে পারলে ভালো, না বলতে পারলে আরো ভালো। Coming to laboratory diagnosis, what could be the specimen that you will be interested to collect? Most commonly, if the child is able to provide sputum sample, that would be the best sample. But suppose if the patient has respiratory failure, the patient may be intubated. At that point of time, we may have to go for invasive sampling like endotracheal tube aspirates, and if bronchoscopy is done, bronchoalveolar lavage. Sometimes in very small children we may even go for gastric aspirate, because in small children they swallow the sputum. Okay, so gastric aspirate may be collected. Now what to test in those samples? In these respiratory samples we will be going for direct microscopy to look at microscopy তে কি দেবো আমরা? স্পুটামে কি দেখতে হবে? আর we have to look for the squamous epithelial cells. If the squamous epithelial cells are high in number, that means there is salivary contamination. If it is low in number, that means the sputum specimen is a good specimen. And if it is indeed an infective process, pus cells will be huge in number, and we may also find microorganisms depending on the morphology. Gram positive hote pare, gram negative hote pare, bacilli hote pare, cocci hote pare. For example, in case of strep pneumonia, we can find gram positive diplococci. In case of staph aureus, we may find gram positive cocci in pairs and clusters. In case of gram negative like Klebsiella, we can find gram negative bacilli. Then what we can do? We can go for culture of the sputum sample. The ideal culture media would be both blood agar and chocolate agar. Why chocolate agar? Because chocolate agar is prepared by, there are some inhibitory substances in the blood which are not present in chocolate agar. Hence, fastidious organisms can grow on chocolate agar which do not generally grow on blood agar. Next, we can go for identification of the organism depending on whether it's a gram positive or gram negative or a cocci and bacilli with the help of the biochemicals. Now coming to other tests, what we can do is we can take the blood sample and go for blood culture, because if lungs are infected, there is a high probability the organism may seep into the bloodstream also. Hence, you can also send for blood for culture. Many a times, LRTI are associated with pleural effusion. So if there is significant pleural effusion, you can take the pleural fluid out and you can also send it for microscopy and culture. If you look at these organisms which commonly causes pneumonia, you will find these are the same organisms which can also cause meningitis. And if you look at the pathogenesis of acute bacterial meningitis, you will find these organisms are acquired through the respiratory route, and from there it reaches the meninges. Hence, there is a high probability that this child may eventually develop meningitis. And if the child has signs and symptoms of high fever or even say signs of meningism, we may also need to take the CSF sample and look if the child is suffering from meningitis or not. Okay. Then after the culture, what we can do? We can go for antimicrobial susceptibility testing, which will help us in initiating or directing towards specific or definitive antibiotic therapy. We can also go for other non-specific investigations like CRP and procalcitonin. What are these? These are the markers of acute reaction. That means acute phase proteins, CRP. They rise when there is active inflammation going on in the body. Okay then. Next question. A college student, 22 years, presents with a 10-day history of dry, hacking cough with mild fever, about 105 degrees Fahrenheit, persistent frontal headache, generalized myalgia. His symptoms started gradually. On examination, he looks tired but does not appear acutely ill. The pulse rate is 82, respiratory rate is 18, chest sounds are remarkably clear. Chest X-ray reveals a diffuse patchy bilateral interstitial infiltrate. That means peribronchovascular shadows. That means round surrounding the bronchus. That appear much more severe as compared to the patient's clinical condition. That means the X-ray shows much more shadows, but the patient appears to be not so ill. বোঝা গেছে কোশ্চেনটা কি জিজ্ঞেস করা হয়েছে? এবার বলো প্রভিশনাল ডায়াগনোসিস কি হতে পারে? কি বলেছে এটা? 10-day history of fever, myalgia, respiratory symptoms. That means this could be a case of lower respiratory tract infection. Furthermore, the chest X-ray shows interstitial infiltrates. That means there is an ongoing infective pathology. However, the person does not appear to be so ill. What could be this? This is a case of atypical pneumonia, also called as walking pneumonia. Walking pneumonia কেন বলা হয়? The patient has pneumonia but is able to walk around and do the normal activities. Hence, it is called as walking pneumonia. Okay. So, this is also we can diagnose as atypical pneumonia or walking pneumonia. আগে বলা হতো walking pneumonia, এখন বলা হয় atypical pneumonia. The most common causative agents of atypical pneumonia among the bacterial causes will be Mycoplasma pneumoniae, Chlamydophila pneumoniae, Legionella pneumophila. Among the viral causes, we have influenza viruses, respiratory syncytial virus, and adenovirus. Now remember, RSV causes much more illness in children, but in adult it may cause atypical pneumonia. Other than that, fungal causes can be seen in case of immune compromised. Okay. Now, how can we diagnose? বলো, যদি এগুলো হয় কিভাবে ডায়াগনোসিস করব? বলতে পারবে? দেখো, first things, these atypical organisms are fastidious. They lack cell wall and are obligate intracellular organisms. Hence, if you send routine sputum for culture, that would be inconclusive. ঠিক আছে? And in gram stain, you will only find pus cells with lack of microorganisms. ঠিক আছে? তুমি ধরো এই পেশেন্টের স্পুটাম পাঠিয়ে দিলে মাইক্রোস্কোপি আর কালচারের জন্য, মাইক্রোস্কোপি রিপোর্ট কি আসবে? say plenty of pus, no microorganism seen, culture growth আসেনি, তুমি কি ভাববে? It's a non-infective process, but here you are actually wrong. If you look at these organisms which commonly cause atypical pneumonia, you have the viral causes. Obviously, they will not grow. Among the bacterial, they are fastidious. Hence, they will not grow normally until unless you intimate the laboratory. So, what you need to do? You can send a nasopharyngeal or a throat swab and go for nucleic acid amplification test for viruses. ভাইরাসের জন্য আমার কি লাগবে? PCR করতে হবে, NEET টেস্ট করে, তার জন্য আমার সোয়াব লাগবে। As far as the bacterial samples are concerned, either sputum or bronchial lavage can be sent. Best method is again go for PCR. Legionella and Mycoplasma can be grown on specific culture media, but if you do not intimate the laboratory before sending the sample, most likely you will miss the diagnosis. Alternatively, you can send for molecular assays both for the bacterial and viral pathogens, which can reliably detect these pathogens. Nowadays, multiplex PCR, এটা পড়ে দেখো, multiplex PCR এর একটা commercial platform is BioFire. It detects almost all the respiratory pathogens with the help of a molecular test. So these modules can help us in diagnosing the agents of atypical pneumonia. Well, okay. Now, if you specifically need to go for culture for Mycoplasma, you need to send specific media. Mycoplasma colonic axis গুলো পড়ে নেবে, Friday colonies থাকে, Legionella এর জন্য buffer chart called yeast extract agar lage, that's a specific agar. Okay, and in case of chlamydia, it does not have a cell wall, does not grow on artificial media, so it needs a cell culture media. So culture can be done but on cell line. Okay, moving on. Antibiotic কি দেবে বলতে পারবে? Atypical pneumonia কি ম্যানেজমেন্ট করবে? পজিটিভ এজেন্ট তো এইগুলো, কি ম্যানেজমেন্ট দেবে? অ্যান্টিমাইক্রোবিয়ালস পড়েছো না পড়োনি? হ্যাঁ, পড়োনি? কবে পড়বে? টার্ম তো শেষ হতে চললো। The point I want to highlight is, if you look at all these organisms, they are cell wall deficient. So if you go and prescribe beta-lactam antibiotics, they will be ineffective, because beta-lactam antibiotics exert their effect working on the cell wall. But these organisms lack, although they are bacteria, they lack cell wall. Hence, if you prescribe beta-lactam antibiotic, the treatment will be ineffective. So what is normally given are macrolide group of antibiotics. কিভাবে কাজ করে ম্যাক্রোলাইড? কোশ্চেন জিজ্ঞেস করলেই সব পাথর হয়ে যাচ্ছে। A 28-year-old male was admitted with complaints of low-grade fever, loss of weight, chronic cough with expectoration for past 6 months. What will be your provisional diagnosis? Complaints of low-grade fever, loss of weight and chronic cough for more than 6 months. কি হবে diagnosis? অমিতাভ বচ্চন এসে অ্যাডভার্টাইজমেন্টে বলে যাচ্ছে 2 हफ्ते से ज़्यादा खांसी है तो डॉट सेंटर जाइए. So this is a case of pulmonary tuberculosis. Remember, tuberculosis is the name of the disease. It's not the name of organism. Organism name is Mycobacterium tuberculosis. ঠিক আছে? Many a times another mycobacteria called non-tuberculous mycobacteria, it can also cause similar disease. That is also pulmonary tuberculosis. Now coming to laboratory diagnosis, what will be the specimen in this case? The ideal specimen would be a respiratory specimen. It may be sputum, it may be ET aspirate, bronchial lavage, and even gastric aspirate in small children. And if you are suspecting of extrapulmonary tuberculosis, the sample will depend on the site of the infection. If it is Suppose you are suspecting about lymph node tuberculosis, it will be FNSC from the lymph node. If you are suspecting about, say, organ specific, suppose tubercular meningitis, then the specimen would be CSF. So, depending on the type of the organ or the system involved in extrapulmonary tuberculosis, the specimen would vary. Now, for laboratory diagnosis, this is very important when we are sending respiratory sample. Obviously, the respiratory sample will have commensal microorganisms of the oral flora. Hence, decontamination is very much required. Otherwise, the organism, that is the Mycobacterium tuberculosis, may not be recovered in culture. So, what is this method? It is digestion, decontamination, and concentration. It can be done with two techniques. Either we can use the modified Petrov's method, where we are using 4% sodium hydroxide, or we can use the NaLC or NALC NOH method, that is N-acetylcysteine. Okay, so these are the two methods by which the sputum sample can be processed, and after processing of the sample, we can send the sputum for first is microscopy. The ideal microscopic method would be a Zn stain preparation with 25 decoloration by 25% H2SO4, or we can use fluorescent method, that is automatic staining, and use a fluorescent microscope for detection. Advantage of fluorescent microscopy is the chances of missing the bacilli are much lower in case of a fluorescent microscopy as compared to Zn stain. Next, the same sample, obviously after decontamination, we can send for culture for Mycobacterium tuberculosis. The culture can be done either on solid media or on liquid media. What you need to remember is, in India we have a national program that is called as the National Tuberculosis Elimination Program, and according to that program, every district has a culture and susceptibility center. So if you are suspecting the patient is having tuberculosis, you must send the sputum sample of the patient for culture and sensitivity. Now both the culture and sensitivity can be done either on solid agar or on liquid agar, and the liquid method can also be done on automated machines called as MGIT or Mycobacterial Growth Indicator Tubes. Advantage of automated MGIT are rapid diagnosis. If you go and read your textbook, you will find that for solid culture, it takes at least about 8 weeks for the culture to come up. In case of MGIT, the growth comes round about 1 to 2 weeks. So there is a huge difference in the time required for diagnosis. After that, we can also go for susceptibility testing. Now this susceptibility testing can be done with the help of molecular methods or direct antimicrobial susceptibility. Now in case of tuberculosis, this is very, very important because India not only has a huge number of TB patients, but there is a rising problem of multi-drug resistant tuberculosis in India. Multi-drug resistance can be detected either with molecular methods, including CBNAAT. There are two platforms there are, one is called Gene Expert and the TrueNAAT. So this CBNAAT can detect, and also we can go for the drug susceptibility testing. Okay, এই পয়েন্টগুলো মাথায় রাখো, পরীক্ষার খাতায় এই পয়েন্টগুলো লিখতে হবে। Now, this is the protocol that is given in the national NTEP program, where একদম উপরে দেখো, suppose we have a presumptive patient in whom we are suspecting that the patient could be of tuberculosis. So what we need to do, we need to confirm tuberculosis. If we are able to confirm the diagnosis microbiologically, we can label the patient as microbiologically confirmed tuberculosis. Many a times we may not be able to do so. In that case scenario, we have to label the patient as clinically diagnosed tuberculosis. ঠিক আছে, কিরকম ভাবে হবে? First, we can take the sputum sample and go for smear examination and CBNAAT directly. Okay. Now suppose if it comes positive, then we can label the patient as microbiologically confirmed tuberculosis. And we also need to go for a chest X-ray, especially in case of pulmonary tuberculosis. It will show signs of infection with tuberculosis. Now, if the microscopy is negative but the chest X-ray is suggestive of tuberculosis, we can label it as clinically confirmed tuberculosis and proceed for the treatment. Now, when we start anti-tubercular therapy, what we need to consider is whether this patient is having drug-resistant TB bacilli or not. If it is not drug-resistant, we can start the first line anti-tubercular therapy. And if it is indeed resistant to either isoniazid or rifampicin, the two most important drugs in first line therapy, we have to label it as drug-resistant TB and start second line therapy. বুঝতে না পারলে বলবো আবার বলে দেবো. So this is the normal process. But suppose if the patient has some history of immune compromise, coming in contact with other TB patients or drug resistant TB patient, or the patient is having extra pulmonary tuberculosis. In that case scenario, we have to go for CBNAAT, that is the PCR. And even in that case, if it comes positive, we can send for detection of resistance. If it is resistant, that means resistant to rifampicin, we can start second line therapy and go for resistance testing against second line of drugs. এবার যদি সেকেন্ড লাইন অফ ড্রাগসেও রেজিস্ট্যান্স আসে তখন আমরা ওটাকে বলি XDR or pan drug resistant TB. Okay. Now look over here. If CBNAAT is not available and the microscopy is negative, then we can label the patient as clinically diagnosed tuberculosis. ঠিক আছে, বোঝা গেছে চারটা? রেসপন্সিভ হচ্ছে না. Have you understood this one? মোবাইল ট্যাবলেট না ঘেটে যখন বলছিলাম তখন শুনলে নিশ্চয়ই বুঝতে পারবে. Do I have to repeat or I'll move on? Next question. A 3-month-old infant is brought to the emergency room with a 3-week history of worsening cough. The child has not yet received his routine primary immunization. The illness began with a mild cough-like symptoms a week ago and then progressed to severe uncontrollable coughing fits. During an episode, the infant had series of 10 to 15 consecutive rapid coughs during a single expiration, followed by a high-pitched rushed inspiratory gasp. The infant's face turned bluish during the fit, ending with vomiting. The vomitus was clear mucus. Blood examination shows leukocyte count of 38,000 per microliter with 75% mature lymphocytes. That means absolute lymphocytosis. What will be your provisional diagnosis? কি হলো, একটা বাচ্চা এসছে, এক সপ্তাহের হিস্ট্রি আছে, প্রথমে হালকা জ্বর কাশি দিয়ে শুরু হয়েছিল. প্রেজেন্টলি mother complains that the child is having paroxysm of cough, 10 to 15 cough constantly, to such an extent that the child's face turned bluish. তার মানে কি cyanosis হচ্ছে, and sometimes it ends up with vomiting, but the vomitus is clear mucus. Blood picture shows leukocytosis with absolute lymphocytosis. কি মনে হচ্ছে কি হতে পারে এটা? Better is use the word pertussis. The disease is called as pertussis. আর একটা কি নাম বলে একে? আর কি নাম বলে? So, what could be the possible etiologies? Pertussis is caused by Bordetella pertussis. But similar presentation can be seen with Bordetella parapertussis, other bacterial infection like chlamydia, and viral infections like RSV, adeno, and parainfluenza. এখানে দেখো চাইল্ডহুড রেসপিরেটরি ইলনেসে এই ভাইরাসগুলো কমনলি থাকে. কি কি? RSV, adeno, parainfluenza virus. Okay, so these can also present like this. ঠিক আছে, জাস্ট হিস্ট্রি ইজ সাজেস্টিভ অফ হুপিং কাফ, তার মানে এইটাই নয় এটা হুপিং কাফ. You can only label it as pertussis after you confirm with laboratory reports. So how will you proceed? Now keep in mind Bordetella pertussis is extremely fastidious. Fastidious means it will not grow on regular media and it is very fragile. Fragile means কি? Easily মরে যায়। Easily মরে গেলে কি হবে? হসপিটাল থেকে ল্যাবরেটরিতে যদি ট্রান্সপোর্ট করতে দেরি হয় মরে যাবে। অ্যান্ড স্ট্রিক্টলি এরোব, তাহলে এরোবিক কন্ডিশন মেনটেন করতে হবে। এই তিনটে মাথায় রেখে কী কী নিতে হবে দেখো, বিকজ there are viral etiologies, you have to take a nasopharyngeal swab and send for PCR assays. Other than that, what we can do is we can collect the sample right on the patient's bedside. And you should be very, very careful while taking a sample in this patient, because just introduction of a swab into the oral cavity may trigger a paroxysm of cough. So you should be very, very careful. Okay. Next, you have to inoculate the plate right at the bedside. এমন নয় যে সোয়াবটা নিলাম, কন্টেনারে রাখলাম, ল্যাবে পাঠিয়ে দিলাম। By the time it reaches the laboratory, even within 30 minutes, the bacteria will die. So what you need to do? You need to take the culture media into the bedside, take the sample with assistance of airway management. মানে সাপোজ তুমি এয়ারওয়ে ম্যানেজ করতে জানো না, তাহলে একজনকে আগে কল করো who can manage the airway in case of paroxysm of cough. ঠিক আছে? With preparation, then take the sample, inoculate right on the bedside. Now, if you cannot do so, you have to send it with a transport media. Commonly Amis transport media use korte paro, that is commonly used, or specifically you can use Reagan-Lowy transport media. Now culture media for Bordetella is Bordet Dengue medium or Reagan-Low media. This is the culture media. Okay. Now because nowadays molecular assays are much more sensitive and specific, you can directly go for molecular assays. Another method is by direct fluorescent antibody testing. Any idea what direct fluorescent antibody testing is? Basically, with the use of the hybridoma technology, we produce antibodies against this organism in the laboratory and tag them with fluorescent particles. Then we take the clinical sample and we treat with this antibody. After washing, if you observe it on the microscope, we can find fluorescent particles. If the fluorescent particles are there in the clinical sample, that means where was the fluorescent particle originally tagged to? It was tagged to the specific antibodies. That means those antibodies are present in the specimen. And where these antibodies will tag on? They will tag on to the microorganisms. So this is the way we can detect. Okay. A very prudent indicator of pertussis is absolute lymphocytosis. What is absolute lymphocytosis? And what is relative lymphocytosis? Acha, what are the parameters that we check in a CBC? কি কি প্যারামিটার চেক, এটা তোমাদের বলা উচিত, প্যাথোলজিতে তো পড়েছো। কি কি দেখা? আবার এত শর্ট ফর্ম কেন? হ্যাঁ, ডাব্লিউবিসি প্যারামিটার কি কি দেখা হয়? প্রথম কি দেখা হয়? টোটাল লিউকোসাইট কাউন্ট, দ্যাট মিনস অল দ্য ডাব্লিউবিসিস কাউন্ট। নর্মাল রেঞ্জ কত? ঠিক আছে, 4 থেকে 11 হয়। তাহলে if it is more than 11,000, then we call it as leukocytosis. That means WBCs have increased. Now this can be because of any of the fractions. What are the fractions? Neutrophil, lymphocyte, basophil, eosinophil, তাই তো? Now suppose neutrophils increase in number, তখন আমরা ওটাকে কি বলি? আচ্ছা, what is differential count? ডিফারেন্সিয়াল কাউন্ট মানে ডিফারেন্ট কাউন্ট। কি বোঝো, আমি ডেফিনেশন জিজ্ঞেস করছি, কি বোঝো ডিফারেন্সিয়াল কাউন্ট বলতে, কি বোঝো, কেনই বা করা হয়? তাতে কি হলো, তাতে কি হলো? কেন হঠাৎ করে এত নরবার চেম্বারের মধ্যে ঢুকে কাউন্ট করে এই করে সেই করে এত কষ্ট করে ডিফারেন্সিয়াল কাউন্ট করা হয়, কেন করা হয়? পারপাসটা কি? তারপরে আমরা আবার দেখছি অ্যাবসলিউট কাউন্টটা, অ্যাবসলিউট নিউট্রোফিল কাউন্ট কত, অ্যাবসলিউট লিম্ফোসাইটের কাউন্ট কত। তাহলে অ্যাবসলিউট যদি আমাকে দেখতেই হয়, তাহলে আমার ডিফারেন্সিয়াল কাউন্ট দেখে লাভটা কি হচ্ছে? দেখো, common bacteria, extracellular bacteria, some of the intracellular bacteria, most of the fungus, they trigger neutrophilic reaction. তার মানে যদি ইনফেকশন হয় নিউট্রোফিলের নাম্বারটা বাড়বে, বোঝা গেছে? এটা অ্যাবসলিউট নিউট্রোফিলের নাম্বার বাড়বে। ভাইরাসেস অ্যান্ড intracellular bacteria, they will lead to rise in number of lymphocytes. ঠিক আছে? If we only look at the differential count, we are taking a ratio. That means if we take 100 leukocytes, out of the 100, how many are neutrophil, how many are lymphocyte, that is a ratio. But when we take the absolute count, that means absolute number of neutrophils and lymphocytes etc. have increased or not. ঠিক আছে? In some of the infections like this, the number of the lymphocytes increase drastically. The neutrophils number may be normal. বোঝা গেছে আমি কি বলতে চাইছি? রেশিও অল্টার হতে পারে। নর্মাল যেটা আমরা নিউট্রোফিল লিম্ফোসাইটের যে রেশিওটা দেখি, the ratio may be altered. It may be altered because either the neutrophil may go down, but the lymphocytes are same in number. In that case scenario, the ratio may be altered, or the neutrophil may be normal, but the lymphocyte have raised significantly high. Even in that case scenario, the ratio may be altered. So this is one of the scenarios in which, because of the raised lymphocytes, the ratio may be altered. বোঝা গেছে? Hence, it is called as absolute lymphocytosis. Okay. Now, it's very important that in case of pertussis, we actually vaccinate, especially the children, with a vaccine called as the DPT, diphtheria, pertussis, and tetanus. P stands for pertussis. The pertussis can be either a whole cell or acellular, commonly vaccinated at 6, 10, and 14 weeks. Antibiotic macrolide can be given. Alternatively, cotrimoxazole can also be given. Okay. Now, let us look at another case. A 45-year-old male was admitted into the ICU following severe head trauma after a motor vehicle accident. He was intubated and placed on mechanical ventilation upon admission. On day 6 of mechanical ventilation, that means 6 days after he was intubated, he develops fever. Respiratory findings যেগুলো দেওয়া আছে সেগুলো বুঝতে পারবে না আমি জানি, তবু আমি বলে দিচ্ছি। ফার্স্টে দেখো কি বলছে, yellowish secretion on endotracheal tube. That means whatever secretion that was aspirated from the tube have turned yellowish, from clear mucoid to yellowish, then falling in oxygen saturation, means SpO2. সেটা স্যাচুরেশনটা ফল করছে, and increase in FiO2. এই তোমরা ফিজিওলজি পড়ে যেত, হোয়াট ইজ FiO2? বেসিক্যালি স্যাচুরেশন পড়ে যাচ্ছে মানে কি, পালমোনারি বেড থেকে অক্সিজেন ইজ নট রিচিং দ্য ব্লাড, তাই তো? FiO2 ইনক্রিজ হচ্ছে মানে এয়ারের রিকোয়ারমেন্টটা বাড়ছে। রিকোয়ারমেন্টটা বাড়ছে কেন? অক্সিজেনেশন হচ্ছে না, সো মোর অ্যান্ড মোর অক্সিজেন রিকোয়ারমেন্টটা বাড়ছে। On auscultation, we can find coarse crackle in the right lower lung field. On imaging, there is opacification in the lung. Laboratory report shows leukocytosis. কি দাঁড়াচ্ছে এই কেসটা? What is this case? The patient was kept in ICU, required mechanical ventilation 6 days after intubation, started developing various signs and symptoms. The first is the aspirates turned yellowish, saturation dropped, FiO2 have increased. On auscultation, we have findings on the particular right or left side of the lung, and on imaging, we are finding opacification. কি দাঁড়াচ্ছে এটা? একটা পেশেন্টের অক্সিজেন স্যাচুরেশন পড়ে যাচ্ছে, রিকোয়ারমেন্ট বাড়ছে, ইয়েলোইশ অ্যাসপিরেট হচ্ছে, ব্লাডের সেল কাউন্ট বাড়ছে, কি হচ্ছে এটা? লাংসে ফাইন্ডিং পাচ্ছি, কি মনে হয়? LRTI বা নিউমোনিয়া। কখন হচ্ছে? 6 days আফটার ভেন্টিলেশন। তাহলে সেটাকে কি বলা হয়? কি বলে? এটাকে বলা হয় ভেন্টিলেটর অ্যাসোসিয়েটেড নিউমোনিয়া। আরেকটা কথা বলে দিচ্ছি, তোমরা ভেন্টিলেটর অ্যাসোসিয়েটেড নিউমোনিয়া লিখলে ঠিক আছে, বাট a more prudent terminology that is used is called as ventilator associated events. মনে না রাখতে পারলে ভালো, you can go with ventilator associated pneumonia. So what is ventilator associated pneumonia? That means a lower respiratory tract infection which develops after 2 consecutive 48 hours after mechanical intubation. Now what are the organisms which may cause ventilator associated pneumonia? It can be of two types. One is called as early onset. That means within the first 5 days of intubation, or late onset after 5 days. এটাকে কেন করা হয়েছে? Very simple. Within the first 5 days, most common organisms will be acquired from the community, and after 5 days, most of the organisms are associated are hospital acquired organisms. Now look at the organism. Within the early onset, we can find organisms like Streptococcus pneumoniae, Haemophilus influenzae, and Staphylococcus aureus. So these are commonly found in the community. Whereas if the patient develops after 5 days of intubation, most commonly the organisms will be acquired from the hospital environment. Commonly Pseudomonas, Acinetobacter, Klebsiella, and MRSA, that is methicillin resistant Staphylococcus aureus. So now, how can we approach for diagnosis? The best sample would be to take a endotracheal aspirate sample, or we can go for bronchoalveolar lavage. Then send it for gram stain and culture. On gram stain, we can find obviously pustules along with the organism itself. It could be a gram positive cocci or gram negative bacilli. Now this is very important. In endotracheal aspirate, we need to quantify. Now why quantification is important? Because now first things first, endotracheal tube is a foreign body. Whenever we are placing a foreign body in the patient's body, that foreign body will be colonized with microorganisms. Just mere colonization does not mean the patient is having infection. So to differentiate between colonization and infection, what you must understand is, if it is indeed infection, the number of the organism will be sufficiently high. Okay, in colonization the organism may be present, but the number will not be significantly high. Now when I say significantly, what would be the count? These are the count. If we are looking at the sample, that is the sample is endotracheal aspirate, the organism should be at least 10 to the power 4 CFU per ml. If we are taking a bronchoscopic sample, that is the bronchoalveolar lavage, it should be at least 10 to the power 3. That means the more invasive the sample, the count should be higher. Okay, then after the culture, we need to identify the organism based on the biochemical, or we can go for a Vitek or Malitoc, and then go for susceptibility testing. And depending on the results of the antimicrobial susceptibility reports, we can initiate and modify the treatment. So this is how a case of ventilator associated pneumonia may be given. What you need to look is, first thing, the disease process must start after the patient was put on mechanical ventilation. It should be at least 2 calendar days or 48 hours after intubation. Okay. Secondly, there must be clinical signs symptoms. What are the clinical signs symptoms? Fever, yellowish discoloration of endotracheal aspirate of the secretions, pulmonary patches on chest X-ray, auscultatory findings or percussive finding on clinical examination, and ventilatory parameters like dropping of the oxygen saturation or increase of the FiO2. If these parameters are present, then we can label it as a case of ventilated associated pneumonia. Have you understood? Okay. Moving on to the next case, a 28-year-old female school teacher present to the emergency department in January with sudden onset of high-grade fever, severe chills, general muscle ache, harsh dry cough, debilitating headache. She notes her symptoms started abruptly only yesterday, that means 24 hours ago. On examination, the patient has a flat face, watery eyes, inflamed pharynx without tonsillar exudates. Pulse rate is 96, respiratory rate is 20 per minute. The lungs are bilaterally clear with no auscultatory finding. Chest X-ray reveals a normal study. কি হতে পারে? প্রত্যেকটার ক্লু দেওয়া আছে। কি বলা হয়েছে ক্লু? স্কুল টিচার started 24 hours ago with high grade fever, muscle ache, joint severe chills and muscle ache, তার সঙ্গে dry cough. On examination কি বলছে? Pharyngitis red but without tonsillar exudates. That means this is not pharyngitis or tonsillitis. But there is fever, systemic infection. কি হতে পারে? এরকম হয়েছে তোমাদের আগে কোনোদিন? আগের দিন ধরে গা ম্যাচ করছে, শরীর খারাপ হয়েছে, পরের দিন ধরে খুব জ্বর, মাথা ব্যথা করছে, উঠে বসতে পারছো না, হয়নি? স্পার্টান, তোমরা তো সব স্পার্টান বোঝো? হ্যাঁ, সেটাও বোঝো না। মোস্ট কমনলি কি হয়? কারো ফ্লু হয়নি? So your differentials would be influenza A virus and B virus, SARS coronavirus recently যেটা একটা প্যান্ডেমিক হয়েছে, RSV adenovirus. Now coming to laboratory diagnosis, কিভাবে laboratory most of them are viral cause. So most commonly we can go for diagnosis with either rapid antigen test or molecular test. In both the case scenario, you need to take a nasopharyngeal swab. Now keep in mind, the swab should be made of dacron. You cannot use a cotton swab for molecular analysis because cotton is inhibitory for molecular analysis. ঠিক আছে? তোমাদের মধ্যে কজন কোভিডের জন্য টেস্ট হয়েছে? একজন? দুজন? বাকি সব বাড়িতে বুঝছিল নাকি? Those who have been tested upon, have you seen the swab that was used? It's not made of cotton, it's made of a synthetic material that is called as a dacron. Okay, then what would be the test we need to do? We need to go for RT-PCR, that is reverse transcriptase PCR. Okay, or we can go for rapid antigen detection test. Those kits are available, and the best method of diagnosis is obviously if we grow the virus in cell culture. That is only done in reference laboratories, and we need cell line cultures like, at least keep in mind, embryonated egg. Cell line culture মনে না থাকলেও জাস্ট মাথায় রাখবে embryonated egg. ঠিক আছে? ওকে, চলো last question. A 52-year-old male with a history of type 2 diabetes mellitus presents to the medicine OPD. প্রত্যেকটা কথা ভালো করে পড়ে দেখবে। এর আগে যেগুলো ছিল সবকটা কি বললাম? presents to the emergency room. This one presents to the medicine OPD. সেই জন্যই বলছি, whenever you are going through the question, go very carefully. with a 5-day history of persistent dry cough, moderate fever, 101 degree Fahrenheit, profound fatigue, and newly developed loss of taste and smell. মানে পেশেন্ট এসে কি বলছে, 5 দিন ধরে খুসখুসে কাশি, কিন্তু কিছু বেরোচ্ছে না, জ্বর অল্প আছে কিন্তু গা হাত পায়ে সাংঘাতিক ব্যথা, আর তার সঙ্গে কি বলছে, খাবারের স্বাদ পাচ্ছে। যাক, হয়েছে, যাক, চলো পার্সোনাল এক্সপিরিয়েন্স কাজে এসেছে। The pulse rate is 88 per minute, that means normal finding. BP normal, saturation 95 at room air, at rest, but after a 6-minute walk, saturation drops. Mane saturation drops on exertion. Bilateral crepitations can be seen. HRCT of the chest reveals peripheral bilateral ground glass opacities. So this is how a typical case of acute viral respiratory infection presents. ঠিক আছে, যেটা প্যান্ডেমিক হয়েছিল সেটাকে বলা হয়েছিল কোভিড-19, তার আগে অনেক কটা এরকম ভাইরাস হয়েছে, সার্স সিওভি, মার্স সিওভি, বার্ড ফ্লুর নাম শুনেছো, almost all presents with this kind of presentation. This presentation is called as serious acute respiratory illness, or short SARI. Okay. So what could be the causative agent? Obviously, recently, because of the pandemic and the circulating the SARS-CoV strain, we can find SARS-CoV-2, influenza A or B, RSV, adenoviruses, even MERS virus. There are many viruses. They got a parve likhbe. Now again, how can we diagnose? The best method of diagnosis is again molecular test. Take the dacron swab, take the nasopharyngeal sample and send for molecular assay. Preferably RT-PCR and in a transport media containing VTM or viral transport media. এইটা মনে রাখা সবচেয়ে সোজা, ভাইরাসের টেস্ট করতে গেলে ট্রান্সপোর্ট মিডিয়া লাগবে, ভাইরাল ট্রান্সপোর্ট মিডিয়া। ঠিক আছে, তাহলে ড্যাক্রন সোয়াব নিয়ে ভিটিএম এর মধ্যে পাঠিয়ে দিতে হবে। কোথায় পাঠাতে হবে? মলিকুলার টেস্ট উইথ RT-PCR। তাহলে কমনলি আমরা কি কি হয়, কি বললাম, কোভিড কে করে সার্স-সিওভি। প্লিজ ডু নট রাইট কোভিড ভাইরাস, কোভিড ভাইরাস বলে কিছু হয় না। দ্য ডিজিজ ইজ কোভিড-19, দ্য ভাইরাস ইজ SARS-CoV-2। ঠিক আছে, আদার কমনলি ইনফ্লুয়েঞ্জা, মার্স সিওভি হতে পারে, RSV, adenovirus, this could be. Now, the gold standard is RT-PCR. Over here, RT-PCR means real time. এবার কি করে কনফিউজ হবে, এখানে দেখো শর্ট ফর্মটায় লেখা থাকে QRT-PCR. RT stands for reverse transcriptase আর Q stands for real time. রিয়েল টাইম মানে আমি দুভাবে টেস্ট করতে পারি, মেশিনে দিলাম, পুরো টেস্ট রান হলো, তারপরে রেজাল্ট দিই। দ্যাট ইজ দ্য নর্মাল RT-PCR. The advanced method is টেস্ট রানও হচ্ছে, আমাকে প্যারালালি রিপোর্টও দিচ্ছে, দ্যাট ইজ কল্ড অ্যাজ রিয়েল টাইম। ঠিক আছে, এটা নিয়ে বেশি ভয় পাওয়ার কিছু নেই। রিয়েল টাইম মানে যা হচ্ছে সেটা আমরা যেটা দেখছি। আচ্ছা, যাদের কোভিড হয়েছে যদি টেস্ট হয়ে থাকে দেখবে টেস্টের সময় একটা ভ্যালু দিত, সিটি ভ্যালু, শুনেছো না শুনুন? তো সিটি ভ্যালুটা কি হচ্ছে? থ্রেশহোল্ড ভ্যালু। থ্রেশহোল্ড ভ্যালু মানে একটা সার্টেন অ্যামাউন্ট অফ নিউক্লিক অ্যাসিড আসার পরে আমাদের মেশিনটা ট্রিগার করে পজিটিভ হিসেবে। ঠিক আছে, এবার এই নিউক্লিক অ্যাসিডটা বাড়বে কখন? আমি PCR করছি, আফটার এভরি সাইকেল দ্য নাম্বার অফ নিউক্লিক অ্যাসিড উইল ইনক্রিজ, দে একটা সার্টেন টাইমের পরে ইট উইল গো অ্যাবাভ দ্য থ্রেশহোল্ড ভ্যালু, যখন আমাকে ট্রিগার করছে। এবার এই কতগুলো সাইকেল লাগবে সেটা কিসের উপর ডিপেন্ড করছে? পেশেন্টের যে স্যাম্পলটা নিলাম, স্যাম্পেলের মধ্যে ভাইরাল লোড কত আছে। ধরো একটা পেশেন্টের যদি প্রচুর ভাইরাসের লোড থাকে তাহলে কি হবে, কয়েকটা সাইকেল চলার পরে প্রচুর লোড চলে আসবে, তাহলে থ্রেশহোল্ড ট্রিগার করবে, তাহলে তার সিটি ভ্যালু লো হবে। আর একটা পেশেন্টে ধরো খুব অল্প ভাইরাস আছে, তাহলে আমাকে PCR এর সাইকেল 20টা 25টা 30টা সাইকেল রান হওয়ার পরে আমাকে ট্রিগার করছে, তার সিটি ভ্যালু হাই হবে। বিকজ দেয়ার ইজ নট মাচ মেথড অফ measure of prognosis in these cases, the CT value gives a pretty good assessment of the viral load in the clinical sample. ঠিক আছে? Hence you will find the CT value. Alternatively, we can go for rapid antigen test, or we can also detect antibodies against this disease. যেমন কোভিড প্যান্ডেমিক হয়ে যাওয়ার পর অনেকের অ্যান্টিবডি টেস্ট করা হয়েছে এইটা দেখার জন্য যে কারা কারা ইনফেক্টেড হয়েছে হয়নি। কেন? কোভিডের 95% অফ দ্য পেশেন্ট ওয়ার এসিমটোম্যাটিক, অনেকের ইনফেকশন হয়েছে কিন্তু সিমটম নেই, ওই জন্য রিপোর্টও করেন, কিন্তু তাদের যদি আমি পরবর্তীকালে অ্যান্টিবডি টেস্ট করি তার অ্যান্টিবডিটা আমি পজিটিভ। সো অ্যান্টিবডি টেস্টিং গিভস আ retrospective diagnosis. And last but not the least, in all these cases of SARI, that is severe acute respiratory illness, why this is so important? Patient তো apparently অত খারাপ নয়, তাহলে আমরা এত সিরিয়াস হয়ে যাই কেন? Because this virus in the body, it triggers something called as a vicious cycle, and it starts liberating inflammatory cytokines. It leads to massive inflammatory cytokines in the body itself. This leads to something called as cytokine storm. Most of the patients succumb because of this illness. Some of the markers of cytokine are C-reactive protein. It's an acute phase reactive protein. It will increase whenever there is liberation of these inflammatory markers. Or we can detect D-dimer. D-dimer এর নাম শুনেছো? কোথায় ইউজ করা হয়? হসপিটালাইজড আইসিইউর পেশেন্টদের বেশি হয়, যারা এক জায়গায় এক বেডে অনেক দিন থাকে। কি হয় সেটা? যেটাকে প্রিভেন্ট করার জন্য পায়ে কম্প্রেশন দেওয়া হয়, নিউম্যাটিক কম্প্রেসার বা সক্স পরানো হয়। আরে ডিপ ভেন থ্রম্বোসিস ফলোড বাই পালমোনারি থ্রম্বোএম্বোলিজম। আর একটা মার্কার ইজ কল্ড অ্যাজ ফেরিটিন। নর্মালি আমরা ফেরিটিনটা কোথায় অ্যাডভাইস করি? বলো, আয়রন ডেফিসিয়েন্সি অ্যানিমিয়া ডায়াগনোসিস করার জন্য। যাই জিজ্ঞেস করছি সবেতেই চুপ আছে। ফেরিটিন ইজ অলসো আ মার্কার অফ অ্যাকিউট ইনফ্লামেশন, ঠিক আছে?